Okay, I'm going live on YouTube. Perfect. All right. Okay, we're going to start in just about a minute. People are still coming in. All right, okay. Good evening, everyone, and thank you for joining us tonight. My name is Rovina Nimbalkar, and I'm the Executive Director of NAMI Santa Clara County. Before I invite our moderator and our speaker for tonight, I would like to give some updates at NAMI Santa Clara County. So all our programs have been virtual since shelter in place that was last year in March of 2020. Our warm line is up and running from 10 a.m. to 6 p.m. Monday through Friday via phone as well as email. Our after-hour family support is available on evenings and weekends. All our support groups are listed on our website, which is www.namisantaclara.org, and offered over Zoom. For our educational classes such as family to family, familiar to familiar, persona to persona, peer-to-peer, provider education, you can contact our warm line number at 408-453-0400 and select option 1. The peer-to-peer class, the next one is going to start in January. Same with the family-to-family class. It's going to be in January 2022. The provider class, the next one starts October 22nd. NAMI Basics is on demand and on our website, and you can take it at your own pace. Same with the home front. Our FaithNet training, the next one is going to be on Thursday, October 28th at 11 a.m. Our community peer program continues to matches via hospitals as well as self-referrals. Also, do check our website, www.namisantaclara.org. We update our blog section with new articles written by Maureen Milo, who's also our moderator for tonight. NAMI Walks Your Way Silicon Valley was on October 9th, which is this past Saturday. And we're really excited to announce that we've raised about $230,000, which is pretty much what our goal was. So thank you so much to all our supporters and to our sponsors, our team captains, participants, and volunteers, everyone. I also want to mention that NAMI Walks is our biggest fundraiser, and 100% of the funds raised go towards our program. So on October 9th, all the NAMI Walks supporters in Santa Clara County walked for mental health. Please do share your pictures if you participated in the NAMI Walks by tagging us at #NAMIWalksSV. If you want to watch our virtual program, you can visit www.namiwalks.org/Silicon Valley. Our chairperson for this year was Senator Dave Cortese, Congressman Ro Khanna, as well as Dr. Sarah Cody. And our keynote speaker was San Francisco 49ers offensive lineman Laken Tomlinson. Now I would like to introduce our moderator for tonight. Moderator is Maureen Milo. Maureen is a veteran journalist and editor. She was a reporter and editor for Silicon Valley Community Newspaper and the editor of Silicon Valley Business Journal. In 2012, after her son became ill, Her focus turned to mental health advocacy. She writes articles for the NAMI newsletters, blogs for websites, and posts interviews and individual advocating for changes to mental health system. Morit is also on the board of NAMI Santa Clara County. And now I would like to introduce our speaker for tonight, Dr. Tom Insel. In 2015, after 13 years as a director of National Institute of Mental Health, Dr. Tom Insel decided to leave the government's scientific approach to mental health and look deeper into problems and treatment for those with severe mental illness. He moved to California, where he led the mental health team at Verily, a Google X spinoff, and then went to co-found several mental health startups, integrating technology with tools to help those with severe mental illnesses. Most recently, he co-founded Humanest Care, a therapeutic online community for recovery. Dr. Insel serves as special advisor to California Governor Gavin Newsom and is the chair of the board for the Steinberg Institute. He's currently developing Mindsight News, a nonprofit digital publication focused on mental health issues. The website is slated to launch this fall. So I hand it over to Morit to begin the session.
Thank you, Ravina. And Tom, thank you so much for joining us this evening. It's really an honor to have you. So,
well, thank you for having me. It's a real pleasure. And I appreciate those of you who are foregoing the Giants-Dodgers game to actually join this conversation, because I know we have a lot of competition tonight, Morit. This could be this could be the last game of this series.
Yes, right. That's right. Right here. But let's talk about mental health right now. So, you know, some might say that after 13 years with the National Institute of Mental Health, you left and became a bit of a renegade. You admit that life for those with severe mental illness has become actually worse over the last 50 years due to criminalization, homelessness, and inadequate services. And you make the case that in all other areas of medicine, cancer, heart disease, diabetes, we've made great strides, but in mental illness, we've fallen greatly behind. Talk a little bit about, you know, this candid assessment, which is a direct shift from all the work you were really doing over at the Institute.
Well, yeah, thanks for setting that question up. I think it is kind of an inconvenient truth that things have not improved as much as we might have hoped over these last 4 or 5 decades. You know, the irony of that is in some ways the progress has been miraculous on the science side. So when you look at how far we've come in terms of the scientific advances, and also I would say in terms of what we can now offer in the way of treatments, one would think that we'd be much, much further along in terms of population outcomes. So, you know, how many people are in recovery, how many young people are finishing their education in spite of having a serious mental illness. And so, yeah, I think that inconvenient truth is that in the face of so much progress on science, so much progress in opportunity for care, we've actually failed to deliver in such an egregious way. And to be in a world where there are more people in the criminal justice system than in the healthcare system with serious mental illness, that's the piece that really stands out for me, that you wouldn't say that about where we have come in cardiology or oncology or almost any other part of medicine. Because when I started 50 years ago, we didn't lock people up because they had schizophrenia. We didn't expect people to become homeless. We didn't allow them to become homeless. We actually had a more comprehensive care system. Now, that contrast is just really brutal to realize that in those other parts of medicine, we've done much better by people, particularly people with the most severe illnesses in cancer and heart disease, and sometimes I would say in diabetes as well. The outcomes are far, far better than they were 2 or 3 decades ago. But on a population basis, that's just not true in mental health. And that's, to me, this really unacceptable insight that we've got to look at very carefully.
And each state has sort of taken their own path as we, you know, deinstitutionalized and people ended up on the streets. And then from the streets, the community service that should have been there, that fell short when funding wasn't there. And now we're stuck in this quandary. Our state is, of course, no exception. We're sorely behind in a lot of ways. You know, you came out here to get involved in several healthcare startups, but you also took on this advisory role with the state and the governor. And you learned we have 58 counties that live in their own little nation, so to speak, and they all provide different services in different ways. You know, what came out of it for you? I mean, this is a clearly unapproachable way to do, you know, to help the mentally ill.
Yeah, so Maureen, that's a really good summary. I had been working in a couple of different startups, one out of Alphabet or Google, and then one called MindStrong that was really focused on sort of using smartphone signals to figure out when somebody was in need of care. And, you know, there were a bunch of really interesting opportunities there, I think. But we I guess it was about, almost now 2 full years ago when, or 3 years ago, when Governor Newsom, before he became governor, when he had been elected but hadn't gone through the inauguration yet, he reached out, and I went up to Sacramento, and I didn't know him. I hadn't met him before, but we had this really interesting conversation. And he started off by saying, you know, I used to be mayor of San Francisco. I knew that. And he said, when I was mayor, the two big things I struggled with were homelessness and the crowding in the jails. He said it wasn't until, and I didn't make much progress on those, but it wasn't until I left that I began to understand that both of those problems would not be solved unless we solved the problem of untreated mental illness. So, as he said, in his words, I don't want to make that mistake again. So come on board, help me understand how we can do better. And for a bunch of reasons, I couldn't join, but I volunteered to spend a year kind of being his eyes and ears. And I spent that year traveling the state. And just as you said, there are pockets of real brilliance and exciting innovation and really good mental health care in California. And there are pockets of really atrocious care. And it's entirely dependent on where you live. So I don't think any of us feel that that's the right state of affairs. But what makes California unique at several things, but in the mental health space, probably two. One is that we spend more money than any other state. And the second is that we don't have any kind of central authority. There's no state department of mental health. Almost every other state has they have some office, some department, some individual who is at the end of the day accountable and is also someone who can set sort of basic standards and goals. Doesn't happen here. We just don't have, we don't have any kind of real leadership statewide on the mental health side. So I came away from that experience thinking that it's going to be really important for California going forward to continue to have sort of county-based services, because so much of what happens does need to be locally directed and locally protected. But there needs to be somebody who says, in the state of California, these are the things we're shooting for. This is our gold, our gold standard. These are basic objectives for all 58 counties that need to be met. And that we make a pledge that across the state of California, we will reduce suicide. We will, as the governor has said, we will try to make sure that any young person with a first episode of psychosis will never have a second episode, because we think we know how to do that. And we could set out whatever those goals are, and maybe there'll be 5, maybe they'd be 10, but we'd lay them out in a way that would say, it's up to the counties to get there, but this is what we're asking, because we think anyone in the state of California should know that we're committed to these kinds of outcomes. And that's not happening. I mean, it hasn't happened up until now. It's really a system in which virtually all the money flows to the counties. And the only role of the state is to be a kind of collector of data and money, and to try to ensure the federal government that there is no fraud across the 58 counties. That's basically it. We can do much better.
Well, and the problem is, even with that approach, we still do not execute well. We might be able to get the money down to the counties, but then it's not executed in a manner that is, especially for the severely mentally ill. It's just not carved out correctly at all. So we don't have the services we need down here. And you often hear that states like New York have done a much better job with how they allocate their dollars and the progress they've made. And I think many of the people, I know the people who are listening tonight are very frustrated by the lack of services that are here. Did you provide any advice to the governor to help him change his course?
Yeah. So, I mean, what's happened in the last few months, and I can't take any credit for this. This is not about my own influence, but I think it is. I would probably pass the credit on to Mark Galley, our current Secretary of Health and Human Services, who is a pediatrician who cares deeply about these issues. And, the governor and the legislature has made this remarkable, really historic commitment to youth behavioral health. That's a $4.4 billion commitment over the next 5 years. I think conservatively, that is probably 100 times greater than any governor or any state has ever made to this area. That's an extraordinary amount of money. And it comes down to exactly your point, Marie. So now, how do you execute on that? What happens to that? And it's great to have this huge war chest of funds, but what are we going to do to actually have an impact? And where's the money going to go? What are the problems we're trying to solve? And if it's just going to be distributed across 58 counties, good luck with that, because I suspect you'll end up with outcomes that look pretty much like they do today. So again, my point for Secretary Galley and others is it is so inspiring to have this kind of a commitment, but let's get thoughtful about how we execute, and let's get accountable. Let's get to a point where we decide as a state that there are a few things that we need to get done to improve, whether that's access or quality or engagement. We can define what that is and figure out how to measure it. Coming from the tech world, every company I put in OKRs, objectives and key results. And I have to say that when I've sat down with colleagues in Sacramento and said, before this nearly $4.5 billion, what are our OKRs? They have no idea what I'm talking about. So I think we need to build that culture that says, no, there's going to be accountability here. And in this, for this state, if we're going to put this kind of investment in, we're going to expect these kinds of outcomes. And those outcomes need to be measurable. They need to be relevant. They need to be something that we are looking at over a very specific timetable, like you do with objectives and key results, and you actually hold people to performance in that period of time.
Well, I think that in Santa Clara County in particular, we have a group of supervisors that are very proactive towards mental health. But the challenges, especially in Santa Clara County, is we do not have adequate housing. And of course, land here is incredibly expensive. So to provide supportive services, it's that continuum of care dilemma, that you might know what you want to do and how to help the people, but we don't have the professionals here to do it. We don't have the beds. We don't have all the pieces that should make it work. We only now, thanks to former State Senator Jim Bell, do we even have peer certification, which seems like we should have had that a long time ago. And that seems, I know you believe in this greatly, that having peer support and those with life experience is an integral key to helping part of this puzzle.
Yeah. Yeah. So it's incredibly, I mean, there's so many things that need to be done. I guess I would, and if you look at what is coming through this package, it's called the Youth Behavioral Health Initiative. I think it's called Child and Youth Behavioral Health Initiative. And it's available, there's several different renderings of this online, but essentially there are about 10 different pillars in this. It's complicated. There's a lot here. That's why it's, when we talk about execution, it really does require some very careful thought and planning. But one big piece of it, and one that Secretary Ghali talks about a lot, and was one of the things that he first brought to the table on this, was building capacity. Yes, it's remarkable that in Santa Clara, you're very limited in terms of having the beds, having the crisis services, having some of the things you need. But believe me, there is not a bed for a young person who needs help with a behavioral health issue for anyone under the age of 21 anywhere north of Santa Rosa. So you've got 14 counties that don't have a bed. And if you've got someone in Del Norte County, as we do often, who needs to be hospitalized at the age of 15 or 16, you're talking about a 6-hour drive to the closest bed, if that bed were available, which it almost certainly will not be. So we have an extraordinary problem. When we talk about the problem with incarceration and the fact that more people with mental illness by a factor of 10 are in the criminal justice system than in the public mental health care system. It's easy enough to blame the jails and the prisons, but the fact is there is no alternative. We don't have the capacity. I don't talk about deinstitutionalization. I talk about trans-institutionalization. The same time that we gutted the public mental health system, took away all the institutions and the support for that, we invested enormously over those same years in jails and prisons. And that's where the beds are. So that's where people end up going. We have to fix that. We have to begin to now reinvest and create 21st century kinds of facilities. I think we know a lot more than we did 60 years ago or 50 years ago when we were trying to get out of the state system, the state asylums, and build community supports. But certainly one of the things we've learned is that community care and community supports are vital and really important, but they're never enough. You still need the capacity. You need a place for a small fraction of people to go, often for a short period of time. But absent that, you're going to end up with tragedies in jails and prisons where, most people would know that the suicide rate is something like 10x greater than anywhere else in the United States. So we've got some real challenges that begin with some actual building of infrastructure, and there is funding in this new initiative to do that. So I'm actually pretty hopeful that we can do some great stuff here over the next 5 years, but we do have to have a plan.
And how do we, I hear people in my, behind me, even though they're not there, saying, well, what about the people now, the people on the streets?
Yeah.
Need that immediate attention. You have a colleague down in Los Angeles who talked about the 3 Ps, people, place, and what was the last one?
Yeah, so this is a really important insight for me when I was trying to understand this whole notion of recovery. And when I was trying to struggle with this idea of like, so with all this progress, why haven't we done better? Like, what's the gap? Where have we failed to deliver? And I think one of those places we failed to deliver is that we've been so focused on just the kind of immediate relief of symptoms and being in a sort of crisis mode. So we have not a healthcare system, but a sick care system, really, which is all built around crisis, the most expensive and intensive care. We don't really think about long-term recovery. And when I was trying to understand how to think about recovery, I talked to, as you said, this colleague in Los Angeles who's a psychiatrist who works on Skid Row. And he's very experienced. And when I asked him what he thought about recovery, he said, it's so simple. It's just the 3 Ps. And I thought, okay, that's Prozac, that's Paxil. Maybe, I guess psychotherapy is a P, but I don't know that that's what he's. And he sort of saw that I couldn't kind of figure this out. And he said, it's so easy, man. It's just people, place, and purpose. So if you want to help people to recover, you give them social support, you give them sanctuary, you give them a safe and supportive place to live. And then they have to have a reason to live. They have to have a mission, a purpose. And so that is, I think, really, it's been helpful for me in thinking about if we're serious here, and even in the near term, like over the next few months, if we want to start bending the curve, reducing suicide, reducing homelessness, reducing the kind of disability that we see. How could we do that? What are those 3 Ps we could put together, and what are the opportunities for social support? How do we get the kind of environment that we need? And then helping people to have this sense of purpose. And I think some of that is actually very doable with what we know and what we already have in hand, but we're so busy in this crisis mode. It's kind of difficult for us to get past that. And it's, I think, natural that we provide the care that gets paid for, and what, most of what gets paid for, whether it's through public or private insurance, is more standard medical care. So you have to get kind of past that very narrow medical model to really get to a point where people have an opportunity to get the 3 Ps. We know how to do it, but we need to begin to pay for it. We need to make sure we've got the workforce to deliver it. But most of all, we need to have the commitment to actually do it.
Well, we have, the various areas that they're looking at now around the county cities is the county itself and San Jose. They're looking to purchase properties and repurpose them. Many are hotels, and repurpose them now as apartments for those who are homeless. But without the supportive services, a roof over one's head is not going to be sufficient. And then you have the other challenge of the professionals who need to be in our community helping, the psychiatrists, the therapists, the clinical, nurses. Is this a problem? It seems to be a problem throughout the country that we don't have enough staffing. People maybe are not going into the profession as before. There's burnout. People are leaving. Any thoughts on how we can increase the people that we need to help the seriously mentally ill?
Yeah, it's a common question that comes up, and it's a really important one, because workforce is kind of the, that is, I think, one of the most misunderstood areas here. When I was, so I think we'll talk in a few minutes about this book that I've finally finished, and that'll be out in a couple of months. But as part of the book, I was trying to understand. I wrote the book to try to figure out, why haven't we done better? Like, how do we explain this failure? And I asked a lot of people who traveled not just around the country, but around the world, trying to get the better models, better answers, all of that. Many, many people said, well, it's a problem that we don't have access because we don't have workforce. There's a problem with supply and demand, right? Especially with COVID now, huge demand for services, and there just aren't enough psychiatrists or psychologists or social workers or marriage and family therapists. That's not true. Actually, the numbers are stunning. If you look at the data from the federal government, from the Substance Abuse Mental Health Services Administration, SAMHSA, the most recent numbers from 2020, we have about 780,000 people in the mental health workforce. The whole primary care workforce is 200,000 people. The number of people in the dental workforce is about 200,000 dentists and another 80,000 dental assistants. So we're at more than double, almost triple in some cases, any other medical workforce. This is just ridiculous that there aren't enough people when there are, in fact, almost 750,000 people, roughly that many in this workforce. The problem is, A, they don't serve people with serious mental illness. B, they don't have the training to do anything that actually will improve outcomes. And C, very few of them would accept insurance of any kind, public or private, which makes them very different from any other medical workforce. We used to always say that you could never find a pediatrician who would take cash, and you could never find a psychiatrist who would take insurance. I mean, that's striking. So we need to rethink this. I mean, I think the time has come, and I must say that if Secretary Ghali from Health and Human Services was on this call instead of me, and you said to him, what's the thing you really need to do with this, like in California, he would say, we need to rebuild an entirely new workforce. Well, what would that look like? Well, for one thing, we'd have a workforce in this state that would have the diversity of the state, which the current workforce absolutely does not have. The second thing is it doesn't necessarily all need to be people who are certified at a very high professional level. They need to have very good training, but that training can be very focused. And it can also be set up in such a way that they're still learning on the job. I really love what Teach for America did in terms of beginning to rethink the education workforce. And so what I had proposed to Governor Newsom now 2 years ago was something I called Coach for California. So creating a new workforce of 5, maybe 10,000 people, very diverse, probably pulling them from the community college system and giving them the kind of training they would need to be able to work in the school system, to be able to work in the in the child welfare or the homeless system, but to create a workforce that has the diversity, has the language, has the cultural understanding, and the commitment to work within a community that they belong to. We know how to train people up. I'm actually part of a startup that's doing this in Africa, where we're training thousands and thousands of people with basic mental health skills to be able to treat anxiety, depression, PTSD in low-income countries. There's no reason we can't do this in California, but we've got to get over ourselves. We've got to let go of this idea that unless someone has a PhD or an MD, unless they've got 2 years of training with someone who doesn't know what they're doing, and they're therefore certified, then we can't let them see a patient who is struggling with a mental illness. We've got to rethink this, and I think workforce is going to be critical. And that, by the way, as you said, Maureen, is a national problem. Mm-hmm. I was in Boston a few weeks ago, and at a major psychiatric hospital, they were saying, we can't get the nurses. We're going to actually close down some units here, even though there's such a demand on the beds. We're not able to staff them. And so we're not quite there in California, but I can tell you the county mental health system has really struggled with being able to keep people in the workforce in the public sector because they can get paid more at Walmart.
Well, I think that brings up why it's so important that you have people who are peers who have been trained to work. They already lived the experience. They have the lived experience. So they clearly can relate better to anybody, especially somebody with severe mental illness, if they themselves are struggling with that or have learned how to work, in their environment. So it seems like there is a population that we can ask to join the effort. I think NAMI is a great example. They have the family to family and the peer-to-peer program. So some of that infrastructure is actually sitting out there if we just find a way through the resources financially or program wise to tap into that. I think
it's by the way, that's a third P, right? I mean, that's right. Giving those people that sense of purpose or mission that allows them to take their experience and serve others. There's so many reasons to follow that path, particularly now. And I think there is an appetite for that. I think that will will happen. NAMI's been amazing in sort of showing us what can be done and how to mobilize people and use lived experience as part of the solution. So I think we're on that path, but it hasn't happened. It hasn't scaled in the way that it still needs to.
Yeah, I mean, I do think the one good thing, Tom, that has come out of COVID is that sense of transparency now, that mental illness it's still very much has issues with stigma, and in my opinion, it's discrimination towards people with mental illness. But we still have the challenges of parity. We have still insurers that just will not accept mental illness as any something that should be on the same plate as physical illness. They just won't do it.
Yeah.
I don't know what it's going to take, but clearly oversight needs to be out there somewhere, and I'm sure you must see this. They just get away with the ability to set their own timelines with everything.
Yeah, I don't know that that's still going to be true. I mean, there's in the 2021 budget that was passed at the end of last year, there was a couple of pages that got inserted about enforcement of parity. It makes the Department of Labor the home for enforcing parity, and it required the Department of Labor to do 20 unannounced site visits to call the question for major employers about access to mental health services for families. And those 20 site visits had needed to be done within 2021. And at the end of 2021, they had to release a report, which I think we can expect in maybe the last week of December. But any of those companies that are found to be deficient will actually be, they'll literally be humiliated. They will be required by law now to send a deficiency notice to every employee and to make it part of the public record. And so I think for the first time, Parity's been with us since 2009. I think it's 2009, but there's been no enforcement. And finally, we're getting some teeth in this. And you won't really see it until there's a legal process for calling the question and holding people to what the law requires. And it's easy for them to duck it because they can claim that they're providing the services, and yet people still need to go out of network because there's no one within network who can provide those. California, the issue comes up around young people with serious mental illness, where the private sector basically just punts and says, no, it's up to the counties. The counties do this. And that's, again, that's just a unique California problem. But those are the kinds of things that we're going to have to really dig into. And I think you'll be seeing a lot more about enforcement of parity over the next few months.
Well, I really hope so, because I would think that until they're financially penalized, the insurers, I don't see what motivation they would have to change anything. Plenty of them have been embarrassed out here, and they still seem to continue along those lines. So it always has to hit the wallet, the pocket somehow.
It is hard though, Maureen. I mean, I think that they'll complain they don't have the workforce in the same way the public sector says it doesn't have the workforce, and so they too will have to, I think, rethink this a little bit and figure out that we need to come up with some new ways of serving the public here. Like, to me, it's really less about the money and more about it sounds crass, but I think this problem just isn't big enough to them yet. Their real interest is in ICU beds, things that really are expensive. And mental health is like under 5% of the spend. And so it's easy to just let somebody else worry about that. And when you do interact with insurers and with large provider systems, their interest in mental health is only in the way that it affects their medical costs on diabetes or cardiovascular. That's where their money is going. And so they do care about that. And if having untreated depression makes that worse, all right, then they'll actually look at it. But for just someone who has untreated depression and might be 23 or 24 years old, and they don't have a range of other medical problems, there's not a lot of motivation for them.
Yeah, well, well, hopefully that'll change, and we just have to go forward and see what happens. I mean, Tom, to me, it's if somebody is on kidney dialysis, that's a very long-term type of situation. It's a terminal thing in life. You're at dialysis, or you have to go into the hospital because your kidney is not working. Well, severe mental illness is a long-term problem too. And the way to reduce the cost is to get the treatment, right? So you would think that they would look at it that way, even though it's a small slice of the population with a very high end cost.
Yeah, it's just not their problem. I mean, they can pass it off to the public sector and duck it. And that's what they've done in the public sector. The safety net has to suck it up, but it's been underfunded.
Mm-hmm.
I think, you mentioned before this concern about stigma. And I have to say that's a word I try to never use nowadays. I think it's a word that hasn't served us well. And I'm a stickler about words.
Mm-hmm.
The word that you also use, which I think is a far better one, is to call it what it is, which is discrimination. We're sort of in this, I kind of call it the Jim Crow moment for in mental health, where so many people, particularly people with serious mental illness, they're not even on the bus. It's not that they're at the back of the bus, but they're just left out altogether. And the only way to really begin to understand that is that it's more than just a healthcare problem. This is really a social justice problem. It is a form of discrimination, which in some ways right now, if you just look at like life expectancy for someone with schizophrenia, which is, in late 50s, early 60s, it's about 20 some years reduced from the rest of the population. That's a kind of disparity that we don't see for any racial group or any ethnic group in America. This is the most underserved population medically in the United States. It's extraordinary. Life expectancies just like 23 years reduced for someone with SMI, serious mental illness, in the public sector. You got to call that for what it is. It's a kind of discrimination that shouldn't be tolerated. And we don't tolerate that now in terms of racial disparities. Here we've got a medical disparity. We've got people who have a brain disorder, and for whatever reason, and with a long history behind this, we just don't allow them to get the kind of care that could actually help them to recover. And last thing about this is that I think it's because in some odd way, we've decided that the care that we do provide for them is the one thing that they are least likely to follow through on, which is medication. So we've kept this kind of medical model for treating serious mental illness as if it's like an infectious disease. As long as you can get the right antibiotic or the right vaccine in, you're good. You're not. These disorders are categorically different, and they do require a comprehensive approach that's both medical and social and environmental, and it's all those 3 Ps that you have to put in as well. And we're not doing that. We don't even think about that at this point as part of care. But I think if we really are committed to healthcare and not sick care, we've got to get to the point where we say, hey, this is really not acceptable. Our grandchildren will never forgive us for this kind of behavior. This is going to look in 2080 like one of the really sad moments of national behavior. And so we've got to get serious about it and really begin to provide that whole range of supports: housing, social supports, education, all the things that people will need to recover, and to engage people in that process themselves. So this is not just forcing another set of medications on people who, frankly, are going to stop them once they don't have to take them.
Well, I think one of the things you just said too, which is really important, Tom, among many of the things you just said, is that this is an illness that requires engagement. and the individuals who are struggling with a severe mental illness, engagement is a problem. Whereas somebody else in a physical illness, they'll respond to engagement. So we have that additional hurdle that we need to work on. I guess that's why I think peer support is a big factor in hoping to increase engagement. I see that as an advantage, but it's unique in that way, right? Because engagement is such an important element in working with these various, individuals who suffer from schizophrenia.
Yeah, I mean, if you've got almost any form of cancer, the sicker you are, the more likely you are going to get treatment. You're going to do anything you can to get treatment. Once that cancer becomes palpable and is malignant and starts to spread, you are probably going to go after that, at least to get the diagnosis and get the treatment. Same thing is true for heart disease or even diabetes. Mental illness is a little unique that way. It's the sicker you are, the less likely you are to engage. And that's why, one of the reasons why it's been so difficult to bend the curve here. I think people just need to understand that these disorders are a little bit like a wily virus that keeps mutating, so that whatever you throw in, it's going to kind of avoid that intervention. These are disorders which almost by their very nature keep people from getting the treatments that they need. And it's so important that we kind of understand that we understand that's the disease talking. That's how this disease works. And at least in my clinical experience, which goes back quite a ways, all the successes I had would come from when I was able to engage with the person outside of their disease, to begin not to talk about symptoms, hallucinations, delusions, just put that aside. But let's talk about, how are you going to get a date this weekend? Or, when are you want to get back to school? And how are you going to talk to people at school? And you begin to really think through with people the kind of real life situations that they're going to have to face.
Yeah, agreed.
Excuse me, Maureen, I'm just going to interfere. I think a lot of people can't hear you, so your voice is coming out a little muffled. So maybe you might just.
Will that help?
Okay, I think this is great. Yeah.
Okay.
Sorry about that. Didn't mean to.
No problem. No problem. Sorry about that. I didn't realize people couldn't hear me. So, in spite of all of this, Tom, you have tremendous optimism about everything. I believe that is one of the reasons you wrote the book. And the book is Healing: Our Journey from Mental Illness to Mental Health. You want to talk about that a little bit?
Yeah. So, when you write a book, it's best if you're trying to figure something out. At least for me, I when I don't understand something, I tend to start writing, and this started a few years ago, and it was really that conundrum of like, why, as a scientist, I saw just all the spectacular neuroscience that we had done. I co-directed the brain project for President Obama, and I mean that was like a moon project. It was amazing, the kinds of stuff that came out of that and continue to come out. So I was trying to understand, like, why the gap between that enormous progress and the lack of impact. And where I ended up partly was around this idea of recovery, that we just hadn't. We've been focusing on the wrong set of outcomes. The other piece I began to feel was that this really was more than just a health crisis. This was a kind of civil rights crisis or social injustice that needed to be addressed. And so the book really evolved to be kind of a call for action, a call for a new social movement. And it got me really thinking about what that would look like. Now, NAMI is the right place. Like, people at NAMI understand this, because that's kind of, they come to the table with that sort of passion. But the fact is that most of our conversation, whether it's within NAMI or any of the other large national organizations, it's with each other. We haven't yet built a national conversation about this topic. And so I've become really intrigued by How did that happen for civil rights, for marriage equality, for climate change, for lots of other areas where even if we haven't yet succeeded, at least we wouldn't have a presidential campaign without this being on the agenda. We wouldn't expect our public officials to not know about it or not be held accountable about it. And that's just an example. If you're concerned about suicide and you go to your local public official and say, how many suicides have happened in our county, in our district, whatever it is, they will be clueless. They'll have no idea. They could probably tell you about COVID deaths. They could probably tell you about homicides. They could probably tell you about traffic fatalities. Suicide's not on anybody. Nobody's accountable. Nobody cares about it. Nobody's talking about it. So we needed a social movement to begin to make this part of a national conversation with a real commitment to begin to fix things we know how to fix. Part of why I'm so hopeful, and you're right, Maureen, the book I think is hopeful, but I wrote that because I wanted to make it clear that we know what to do. We know what to do, but we're not doing it. And that is inexcusable. So the social movement is to make sure we begin doing what we know how to do. And that has sort of two parts to it. One was the book, and the second was this week launching, well, the website launched last week, the newsletters launched tomorrow, but this new site called Mindsite News, Mindsite with it's MINDSITE, and I think we will put up the link so you can see it. It's a nonprofit. It's free subscriptions for both a daily newsletter and I'll do a weekly roundup. And we have now a bunch of journalists working with us to really dive deep into these questions about how do we actually make a difference? What are we going to do to be able to change outcomes in a real world way? And to tell some of the stories. We call it solution-focused journalism because we do think that the solutions are out there, but they're not scaling and people don't know about them. So we're trying to make that more and more apparent. And then thinking about like, what else can we do? So we've created new advocacy in Washington. There's a group called Inseparable. There's the major advocacy groups, NAMI, Mental Health America, NABH, Treatment Advocacy Center, all of them come together every week. The CEOs meet. We have 15 of us who have been meeting for the last 18 months. Initially it was every Saturday, then it was every Monday, and now it's every other Monday. But we've come up with a kind of unified vision of the things that need to happen to really create this movement. And we're at a time where I think there's really a lot of activity, and you can see it in what's happening for the first time since 1963. There's federal interest in this set of issues. 2 weeks ago, Bennett and Cornyn, a liberal Democrat, a super conservative Republican in the Senate in Washington, released a white paper saying, you know what, mental health is a bipartisan issue. It's a personal issue. It's not a political issue. We need to start doing better. And they laid out in this white paper how bad things are and how much they needed to change. And now we're seeing a set of bills and a set of hearings in a way that we've never had in my almost 50-year career. It's pretty interesting. So I am pretty hopeful that things are beginning to change. NAMI kind of has laid out what that agenda needs to look like. And Dan Gillison, who's the CEO of NAMI National, is deep into this. I mean, he's really, really been extremely helpful in saying, look, it's not a matter of just creating more commitment. It's actually identifying some specific problems and specific solutions that need to be put in place now. And of course, as many of you know, we're starting with 988, which is the new crisis number that is required in every state by July 16th of next year. That will replace 911 for mental health. And what Santa Clara and many other counties have got to be thinking about is, okay, we're going to have a new call center. We're going to have a new number to call. But what happens then? What do they do? Do they call the police, or is there a mobile crisis service that can send a van with a nurse and a social worker and a peer? And if the person in crisis needs to go someplace, where will they go? Do we have the capacity? Do we have drop-off centers, psych emergency rooms? Do we have short-term crisis residential? All those things, which again, we know how to do. We're doing them in some places, but we're not doing them in all 58 counties, and we're not doing them well. So there's a bunch of stuff that needs to happen really quickly. And I think there's a lot of interest right now in making sure that those things go forward.
And it's all about execution, right? Execution and resources and
Yeah,
resources.
yeah, but we know what to do. So the execution problem becomes literally operational. It's not, we don't need to do a lot of research here. And we have great models. We know that places like Tucson and Phoenix and Atlanta and a few others, Denver, you don't have to incarcerate people with mental illness. The rates of incarceration, the rates of mental illness in jails is no greater than it is outside of a jail. We've figured out that you don't have to involve the police very often, less than 1% of the time.
Right.
So we're at a point, we do have these models that we can begin to learn from, but we're not doing that. Mindsight is a way of kind of shining a light on that and making sure people learn from what's working and begin to put that in place.
And is that going to have continuous articles and news? How is that going to work?
Yeah, it's like any social movement. It's going to be fueled with stories every day. We've got, I think we're at 10 or 12 freelance journalists now working on stories. The first set of stories included there was a very powerful first story we did last week, because this is all just happening, but it was a story about juvenile detention during COVID. 30% of the kids went home. The other 70% of the kids went into isolation. Who knew? But for what were called public health reasons, they basically were in solitary confinement for months at a time. 13-year-old kids. So that story got picked up by USA Today. It was on their front page on the day when we released it. But there's just a lot of, there are a lot of stories that need to be told. Absolutely. And a lot of really interesting solutions that also need to be featured. So we're talking a lot right now about crisis and what's happening in many places. So I think, there'll be new stories every day, and we'll be also aggregating stories with a newsletter every day so that you can see kind of like the Marshall Project has done for criminal justice, or Inside Climate News has done for climate. It's essentially creating a platform for a national conversation. Now, part of the reason I want to talk about that is we're also looking for content. So if anybody on this call has something they want to talk about and bring attention to, I'd love to know about it, because we have a whole section for lived experience. We have a whole section for people who want to put in blogs or guest essays. And I think there just has been no opportunity. There's been no platform for this. And I've been stunned, most of all, by the reactions of the journalists that we've gone to, almost every one of whom has said, I really want to work in this area, but there's been no place for me to publish. Right. So we want to make sure that there is a place to publish, and we also want to make sure that people are beginning to read this. So please subscribe and get your friends to subscribe, and and contribute, because we do need the best ideas, and we need a lot. There's a whole section on lived experience. Jamie Raskin, the congressman from Maryland who led the impeachment proceeding and lost a son to suicide in December, Jamie and Sarah Raskin together are going to be leading off our lived experience section by talking about what a family goes through when they lose a child. So I'm excited about this as one of the ways to really stoke this social movement that I think we need.
Well, and very important. I mean, people are always looking for a central place where they can get their information on mental health, over and above NAMI and other outlets that support that, like the Treatment Advocacy Center and many other outlets like that. So before we get to the questions, I want to ask you one last question.
Yeah.
I know that many of the attendees here tonight, their families caring for individuals with mental illness, and individuals are listening with their own mental illness challenges. I believe we probably have healthcare professionals and community activists as well. and everybody's frustrated. So what kind of parting advice can you give? A tall order here.
Yeah, I think the one word that is probably most important is hope. Is to understand that recovery is a real thing, and it's a realistic goal. But you have to work hard to find all the pieces of it. But I find that really hopeful. The fact that there are a lot of people out there who have been very disabled and ill and have recovered and are doing well, and also helping other people to recover, which is so inspiring. So I am hopeful, and I think hanging in there and really now thinking about the 3 Ps: the social support, the place, and the purpose, and understanding that that's really going to be the essence of recovery. It's not just Paxil and Prozac and whatever the other P could be. So I do think that, at least from where I sit, this is a real tipping point. I think we're at a good point where a lot of things are going to be happening, particularly in California. And we are not going to be strapped for resources in the next few years, as far as I can tell. But we do have to get our act together to deliver these things in a way that helps people on people, place, and purpose.
Well, I'm rooting for that, Tom. And
Yeah.
on that note too, I really want to thank you for being with us this evening, and really a real pleasure to be speaking with you tonight. What I'm going to do is turn it over to Ravina now, because I know she's been fielding some questions out there. I can see them on my left eye, right eye on the chat. So Ravina, back to you.
Perfect. Thank you, Maureen. So there are several questions, so I'm going to just go over some of them. So one is, Kaiser offers education and groups online classes through their psychiatry department and trauma recovery and sleep education for insomnia. How do you believe the psychiatric profession could be willing to offer this kind of trauma recovery and restorative sleep education within the public mental health system?
Yeah, it's a great question. And it's interesting. I mean, Kaiser does some things really, really well. It depends on the county. It depends on where you are in the state. Again, it's this sort of local geography. In the serious mental illness space, they're probably less likely to get engaged in most of the state. And so, but if you could get the public sector to learn from some of the things that private sector has done, that would be wonderful. It's tough. I think the public sector is really strapped in a lot of ways. There's a lot of innovation, and there's some great counties. Santa Clara would be an example where some fantastic things are happening. And I think there's a lot of innovation. You happen to have a very good county mental health director in Santa Clara. And so the kinds of things that Kaiser does are absolutely within her purview and something that she would be likely to adopt. I think for her, it's going to be, the questions are really going to be, how do we help someone with serious mental illness to be able to get a life? She's been really focused on that and has done a great job also in thinking about how do we move upstream. So how do we get to people before they're in stage 4? How do we get to them like at stage 2 or stage 1, even when they're struggling? And so I think Santa Clara is probably out front of almost any other county in the state in thinking about that.
Thank you. Thank you for answering that. And then there's another question. If you could comment on the role of social media and mental health, given everything going on with Facebook currently, how can big tech play a role in making things better in mental health space?
Oh, I think about this all the time, and hard to believe with all the news that you see every day. But big tech has actually wrestled with this in some interesting ways. I don't know, when was that? 2016, I think. We had a group across all of the big tech companies, at least any company that had a major social media effort. So it included companies like Reddit and a few others. that we were trying to figure out what we could do about suicide and how to do a better job of both screening for suicide and intervening for suicide. I'm not sure we've ever done it. Facebook, oddly enough, is probably the company that's done the most and seems to have committed the most. Of course, they've got the worst reputation currently. But I think we have to realistically admit that big tech has made a mess of this, and it's probably in many ways made things worse in terms of, particularly for adolescents, in terms of mental health outcomes. Having said that, I think they have the opportunity and the possibility of really doing something, really being part of the solution and not part of the problem. It's just very hard to do right now, and it's very hard to get to kind of the win back the trust from the public. I absolutely believe, though, that if the companies were to go deep into this in the way that some of them are now talking about, this would be a great way to win back trust and to say, we realize this is a national crisis, like COVID was a national crisis. You needed Pfizer and Moderna for COVID. Maybe you need social media companies that are responsible and committed here. And anybody on the call who wants to work on that and who has a foot in big tech, I'd love to connect with them. I've worked with several of the companies. I've started some companies trying to do this. It's really hard, but I think that's all the more reason why we need to get serious about it.
Thank you. Okay, so I'm going to combine two questions here. One is, why can't the government understand the point about only requiring licensed folks to work in this field? And the other question is, why do most mental health therapists not take insurance?
Oh, yeah, those are really important questions. I think the government is coming around, and you have your senator who's now retired to thank for really pushing on peer support and recognizing, though, that even that has to have some sort of certification. So quality matters, having standards matters, and we do have to, whether they're psychologists or peers, we have to hold people to high levels of performance. Why is it, though, that people haven't accepted insurance? And in the book, I think I probably was a little over the top and sort of with some outrage about the fact that 52% of psychiatrists in the United States don't take insurance. The reality is that insurance pays them 1/3 of what they can get from cash and requires a huge amount of hassle on their part and a lot of their time, which doesn't get reimbursed. So I think until both the public and the private system are willing to pay people an amount that works for the providers and protects the consumer, I just don't know that we're going to change that. So it comes down to just basic incentives. And the incentives right now, particularly with COVID, when there's so much demand for care, is that a child psychiatrist can charge $300 an hour. Insurance might pay them $120 or something like that. So you just, it's not surprising that they've decided that they're not going to take insurance, and they're going to, because they can fill up a 30-hour, 40-hour week with people who are willing to pay cash at a much, much higher rate. So that's a fixable problem, but it's not one that anybody wants to fix, because it does mean that insurance companies have to be willing to pay more.
While you're reading that, I just want to interject something. So Jim Beal, the senator, the former senator who you were referencing about peer certification, he offered a fourth P to you, which is political activism.
Perfect. Thank you, Jim. Yeah, exactly. I mean, that's really what the book is about. It's this call for a social movement, which means political activism, and recognizing that, we didn't get to marriage equality, and we didn't get a civil rights movement because we talked about stigma. We got there because we talked about discrimination, and we talked about individual rights and what holding people accountable to providing that. So political activism is absolutely the fourth P.
Back to you, Rufina.
Okay, thank you. Okay, how can youth ages 12 to 24 be helped by online services, given that over half of mental health conditions first present in that age group?
Yeah, so a lot of people are trying to answer that question, Ravina. It's not clear what's going to work. So when I think about where we need to improve clinical care, the three things I usually talk about are engagement, quality, and accountability. And so for young people, if you want to engage them in care, TikTok knows how to do that better than anybody. They know how to do it so well, it's scary how good they are at this. And we ought to figure out how they do this in a way that can be used for a clinical outcome or for something that actually helps people that don't have to have a diagnosis, but maybe just socially isolated or anxious or not sleeping or for whatever reason could use something that engaging in care could help. The other two, quality, I think really is a big piece for young people as well. Getting, for those who are going to need to see a provider, training providers through the kinds of tools we have in social media could be great. And there's some companies like Psych Hub that are just beginning to do that. Super exciting. And accountability, well, that's not on the young people, it's on the providers. But that's another place where technology can really give us the data we need about outcomes, which we just haven't been collecting. And so one of the other reasons why we haven't done better in terms of outcomes, where you don't measure it, you're not going to fix it.
Thank you. The other question is, should we better enforce the grave disability standard for involuntary care?
Yeah, this is a really interesting new area, which I think we have to talk more about in California. I've kind of been surprised that and this is, by the way, something that Governor Newsom is really interested in personally, is trying to get at this grave disability issue, but also just, as he likes to say, we need to rethink the whole issue of involuntary treatment. That, the statute that we work with was from 1967, I think, as he points out. There are not that many things that we use the 1967 solution for anymore. So he's invited the state to really revisit this and ask, what should we be doing? I do think there would be value in at least exploring how grave disability can become part of the commitment standard. And I do think also that when we look at involuntary treatment and commitment in general, we've got to understand that there's sort of a two-sided mandate here. That on the one hand, we're telling people you've got to accept treatment. On the other hand, we've got to provide it, and we've got to provide high quality, comprehensive care, which we haven't. And if you look across the country, and we now have pretty good data about this, the places that have really changed outcomes haven't changed it just by putting assisted outpatient treatment in place, AOT. They've done it by putting AOT in place and then providing an entire bank of care that backs that up. So I do think we have, again, it comes back to accountability. Yeah, it's great to say grave disability is part of the commitment standard, but once you've got that, what do you do with it? What are you going to provide? And I think we haven't answered that question well enough in California. So I hope we're able to talk about both sides of the equation.
Thank you. Have scientists found microdosing for correction of serotonin and cortisol levels to be of help with schizoaffective disorder and schizophrenia?
I don't know the data that says that that's worked. I'm sure there are case reports, but my sense of the randomized controlled trials are that, and I don't know that there's a good RCT on microdosing, but certainly from even going back into the 80s, there's always been a dose-dependent effect. You have to give enough medicine to be able to get a reduction in the symptoms. And I'm skeptical that giving less than an adequate amount is going to make a difference. I'm always open to seeing the data, but I haven't seen good evidence yet.
I see. Okay. There's a question about wanting to know your views regarding Western medications versus holistic lifestyle supplemental brain scan meds and what the future holds.
Yeah, my view is pretty simple. Is comes down to basically saying that I think we should define the problem as a medical problem, and we should define the solutions as being far more than medical. So it's a medical problem. These are brain disorders, and they should get all the same insurance coverage, the same treatments, the same access as any other medical problem. But when it comes to solutions, I think that the medications are probably necessary and not sufficient. And so we should be thinking much more broadly. And that's where this whole thing about the 3 Ps and the recovery model and all of these other issues come into play. Some of that can be holistic, can be non-Western, can be things that people actually are more likely to engage in. But I think if there's one thing that I've learned in my 5 decades of trying to solve these problems is that there's no magic bullet. There's no easy, simple solution. This requires lots of stuff over a long period of time, sometimes trial and error, sometimes combining things, individualizing things. It's not easy. These are really complicated problems. And we're not going to solve them just with medication, but we're not going to solve them with just one of anything else either. It is really a combination of things and a whole comprehensive plan that you're going to need to put in play.
Thank you. And as we thanked Senator Jim Bell, he's actually online watching the webinar, and he says thank you.
Great. Jim, glad to have you with us. Thanks.
Let's see. There's a lot of discussion going on, and I'm trying to skim through questions. If people still have questions, if you can post in the Q&A section and leave the chat section just for discussion, that'll be easy. It'll be easier for me to skim through all of them. So let's see if I can find something. There's a question about, would it help to call this brain illness, as it is an organ and mental illness has more negative connotation?
I've gone back and forth with that. I think that people have used so many different words, and this is one of the reasons why I got so interested in both the book and Mindsight, was just trying to come up with a language we could all agree on, and a language that does justice to the complexity here. I think for some people, calling these brain disorders or brain illnesses helps to say, yeah, these are really severe and these are real problems. On the other hand, for some people, that communicates a kind of hopelessness about them, in the sense that there are many neurological illnesses that we don't really have treatments for, we can't do a lot for. So it cuts both ways. I think it kind of depends on the audience. It's so interesting to me because we've kind of adopted this term behavioral health to describe mental illness, which is a weird way to talk about it, since it's not just about behavior, and there's almost no other area of medicine that we refer to the illnesses in terms of health. I mean, it's a good thing maybe in some ways, but we talk about, we wouldn't call cancer, a cellular health problem. We call it a disease and an illness. And so I think whether you call it mental illness or brain illness, I do think we have to define it as a medical problem and start there. we just don't want to limit our solutions to that. And that's, I think, where we've gone off track.
Thank you. Thanks for answering that as well. I think we have Carol who's raised her hand, and I'm going to allow Carol to speak. So here you go. You can.
Can you
Yeah.
hear me?
We
Yeah.
can. Great.
Okay, thank you so much. Thank you for bringing all of these wonderful points, Dr. Insel, together. And I think also this idea of political activism, maybe you can help us, get our efforts going. I think it takes a lot of us to voice our opinion. And we have an opportunity this week. The jail is asking for public engagement. And I can put the email in the website. Nobody wants to build a new psychiatric unit. And so the County Board of Supervisors are asking us what we want. What does the community want? My son has a severe mental illness. He was incarcerated, went through mental health court. Why did he have to get incarcerated? So what are alternatives? And if we can bring that conversation, especially at the state level, 50% at least of people incarcerated have a severe mental illness. And it just goes back to the things you're talking about. And I think there's some really good ideas in the NAMI webinar, Help, Not Handcuffs, about, community wellness centers. The police take people to EPS, and they're let out on the street and they end up in jail. There's no system. They don't have another means. But if we had community wellness centers dealing with all of these different components of, working with diversion, housing, mobile crisis support, peer support. How do we present this to our leaders, especially since we have this opportunity this week to give them our input? I think the more voices we can, raise when we have this political opportunity. There's money from the county, hearing you say about money from the state. Appreciate your input. Thank you so much.
Well, thanks, Carol. There was a similar moment a couple of years ago in Los Angeles County, and the discussion there was about essentially building a jail for people with mental illness. And the Board of Supervisors kind of got pretty close to that. I think it was going to be this phenomenal expenditure. The number $2 billion comes into my head. That may not be accurate, but it was a big, big number. And as that conversation went on, people started to ask, why are we even talking about this? Like we wouldn't build a jail for people with cancer or heart disease. What are we doing here? And so what they've come up with instead is a very exciting, I think, model system for creating a whole continuum of care for people with serious mental illness and ensuring that they don't become homeless, they don't end up incarcerated. They, taking the criminal justice and the police out of this equation entirely, because they don't want to be there and they don't need to be there most of the time. So I would take a look at what LA County is planning to do. John Franklin Sierra is leading that charge for the county. There are a few other really great examples of things happening like that, where people are building out this continuum of crisis care to ensure that the jails and the prisons are not going to be in the mental health business going forward. Yes, it requires an expenditure of funds, but you can imagine how much you'd begin to save if you don't have to put up another jail because you're trying to incarcerate people with mental illness. So we've done this in the most expensive way, really, and there's just no reason to continue that. So I would strongly encourage you to ask for a kind of a different approach. And by the way, I live in Alameda County near the Santa Rita jail. We just went through something very much like this here, and there's been a number of articles about the Santa Rita jail recently because they've been found to be negligent in the care of people with severe mental illness. So that, that's the same conversation that we're beginning to have here. But I think LA is in front of all of us in terms of coming up with a solution. They do have a whole large proposal. I think I can share that with you if you want to reach out to me offline. And that's really the model that I'd love to see a county like Santa Clara begin to think about.
Thank you.
I think we're getting more questions, but we have about 4 minutes left. So I'm just going to take a few more questions. There's a question, is there a way that we can volunteer to help support these innovative ideas? And there's another question that asks about doing advocacy work in California, and especially in the Bay Area, and who they can contact.
Well, that's a good one for you, Ravina. I mean, I think NAMI is really is ground zero for so much of the advocacy. And so I'm a huge NAMI fan, but there's lots of different advocacy going on. But what I think is so powerful about NAMI is that it's all personal. They have made this family to family, person to person, and now peer to peer. I think it's just so important that you've built out these networks to help people advocate together. And I think the extent to which you can build on that, and people can join that and become not only followers but leaders in that movement. That gives me tremendous hope. I think that is really what we're going to need in every county. And Santa Clara is a bit of a standout. We've got a few other counties that are as successful, but I have to say much of California is really not organized to try to make the changes here that we need.
Absolutely. And I think there's a question about Alameda County too. So I would recommend NAMI in Alameda County.
Right. Yeah. Well, if you can do it, the group that I'm associated with in Eastern Alameda County is spectacular. They meet I think it's every first Monday of the month, something like that. And every one of those sessions is fantastic.
That's great. Thank you. There's a question about, can you please speak to the triple level of suicide amongst veterans who protect our country, not to dismiss civilian suicide? And the person who's asking question, they've lost a lot of family, lots of people to veterans to suicide.
Yeah, so I've been spending so much time talking about how there's no one accountable and how we have done not a very good job for people who really need us. The expression that President Kennedy used in 1963 was, he said, the people with serious mental illness must no longer be alien to our affections. I love that term, alien to our affections. And it was for that reason he brought in the whole community mental health movement. The place where you see that getting resolved, I think, is in the VA. The VA has really made this a focus, and the leadership has been outspoken about the needs to reduce veteran suicide, veterans homelessness, to ensure that there are a whole range of different treatment modalities to engage veterans. And I saw some numbers recently that suggested that they have probably had the greatest success in beginning to reduce suicide, where the rest of the nation has gone up 30% over the course of the last 20 years. The veterans have gone up, and certainly even active duty service members had gone up pretty briskly through over the last decade. In the last couple of years, I think they're really bending the curve, and they're doing a great job. Important to notice that it's not just suicide that you have to worry about. And I think we've failed to understand that, but there's a whole series of other high-risk behaviors that are involved here. And with the work that we did when I was in government with the Pentagon, it became clear that while suicide was part of it, there were an awful lot of deaths from motorcycle accidents that were never really coded as a suicide, but followed all the same patterns. And the same thing with overdoses, which often get labeled as accidental, and yet it's never quite clear in many cases whether those are intentional or not. So I think what we need to talk about are deaths of despair, which are ways of talking about all these different ways that people die. and understanding that for veterans, this continues to be a big issue. But I do have to, hats off to the leadership at the VA that at least has been willing to talk about this in a way that you don't see from most governors, certainly any federal officials.
Thank you. And just one last question. It's thinking of our brains as not being resilient seems like a significant hindrance to recovery. Can the system support us in practicing self-regulation and co-regulation?
I'm not sure I quite understand the question. Can the system help us in?
Can the system support us in practicing self-regulation and co-regulation?
Yeah, those are terms I don't understand very well, so I don't have a great answer for that. It sounds like the question is thinking about, the questioner is thinking about a particular set of interventions that might make a difference for resilience. And I'd love to learn more, but I don't. It's not an approach that I'm expert in.
Okay, that's fine. So I think we're out of time right now. So I'm going to end the session. But before I do that, thank you so much, Dr. Insel, for joining us tonight and speaking with us. This has been so informative, and really, really, we appreciate you coming tonight. And thank you, Morit, for moderating and asking all the questions. And I thank everyone who's attended tonight for taking the time out and joining us. So if you do want to see this video, we have live streamed on YouTube. So you can look up NAMI Santa Clara County on YouTube, and you can watch this again or share with anyone who might be interested. So thank you once again for joining us.
My pleasure. Thanks for having me. And if anybody wants to reach out, I'm sure you'll be able to provide my contact information.
Yes,
Absolutely.
Thank you.
Okay. Thank you so much.
Thank you.
Appreciate it. Have a wonderful evening.
All
Yeah.
right. Take
Thanks.
care. Bye-bye.
Yeah.
Bye. Morit, I might just give you a call.
Okay.
Yeah.
I'm going to sign off. Okay.
Yeah, I'm going to sign off too.
Okay.
Yeah.
Thank you.
Bye.